He has completed his basic medical training in India in 1992, and he worked in India until 1997 when he moved to the UK. After completing his psychiatric practice, he trained as an academic specialist in geriatric psychiatry in the Institute of Aging and Health at the Newcastle University in the UK from 2002 to 2005. He was also a part of the International Lewy Body Study Group based in Newcastle upon Tyne, and he conducted research into treatment and management of the Lewy body disease, focusing on neuro-psychiatric syndromes. Dr. Pakrasi moved to BC from the UK in 2014 and has remained interested in the organic brain syndromes and visual hallucinations. He provides psychiatric inputs in the Movement Disorder Clinic and also works with the Cognitive Health Initiative, the Memory Clinic at the Royal Jubilee Hospital. And his other roles also includes geriatric psychiatry support to community teams, outpatients, tertiary mental health, and long-term care facilities. And I would like to now welcome Dr. Pakrasi. Over to you. Thank you.
Thanks so much, Kelly. Okay, so with that bit of background about me, let's get on to mental illness and Parkinson's disease or psychiatric conditions. And as a matter of routine, I need to say that I have no conflicts of interest, so I'm not trying to sell you anything. That's what it means. And whatever I tell you, they're my opinions. So what I'd like to do today is to try and educate to help you recognize one of the big things that I see we face is this thing called stigma, where it's hard for ourselves to acknowledge or agree that there's something wrong with our minds, brains, and that's something that stops us from seeking help and also stops us from educating ourselves. But really, this is the reason I've left half of the session open. Is, you know, I'd like to hear from you, and if you've got any questions, suggestions, or experiences that you'd like to share, it'll be good. You know, it'll be great to hear from you. So we've got a good half hour for that. So to start off, like Parkinson's disease, almost like Parkinson's disease, all our mental illnesses are syndromes. So they don't have a blood test. It's just we think you've got this, and as a result, that's what we call it. But underlying it is an issue, or we seem to think that these conditions lie in the brain. And by definition, we haven't yet reached the point where we can identify the pathology behind these syndromes. So, of course, why bother? Why bother talking about it? And essentially, as some of you may know, the mental syndromes or the neuropsychiatric syndromes that come with Parkinson's disease and the spectrum of Parkinson's disease disorders impact your quality of life. It causes quite a lot of caregiver or partner stress, and it's behind quite a few people moving into long-term care, which generally people want to avoid. Now, it's also common in Parkinson's disease, and I've just listed some of the common syndromes or symptoms that people get. And there's where I've been able to find some sort of prevalence that is, how many people have the illness or have these syndromes. Uh, and depending on different studies, there's a range. And just to clarify, psychosis, I've said difficulty with reality testing. So we're talking about delusions, so ideas of things that aren't true, or sensory experiences like seeing things or hearing things which other people can't really see or hear. Okay, so I'll just briefly or in greater detail go over these syndromes. And depression, we all say on some day, oh well, today I'm feeling depressed, but it is in our in clinic, it's a clinical condition where there's centrally there's a feeling of feeling low in mood in yourself, but along with that, there's a lack of energy. You feel life is not worth living. Sleep is disturbed, either too much or too little. We don't feel like eating, or we eat too much. There's no real enjoyment, no joy in life. And it can, of course, get bad enough to endanger life when people feel life is not worth living, even though if it is. So it's a feeling that, yeah, this is it, I've reached the end. And there's, of course, loss within Parkinson's disease. There's also changes in the brain chemical makeup. And so there is a good reason, or there are reasons why people get depressed within Parkinson's diseases. And I've just put made out there because it's available to us now as an intervention to stop unbearable suffering. And my job is to try and see if we can do something or anything to alleviate that suffering, and also to try and address any underlying treatable depression that there may be. So a lot of people with Parkinson's and related. So I'm just going to call everything Parkinson's disease and not bother about Parkinson's and Lewy body dementia. But a lot of people have this phenomena of seeing things, and you know that they're seeing things because they never speak. So it's happening in our vision area, which is at the back of our brains, actually. Sometimes people say, I have a feeling of a presence. There's someone in the house, or there's someone just behind my shoulder, and I move to look and there's no one there. Then there are these ideas that my partner's not being faithful. There's suspicion someone's stealing from me, someone's out to get me. And I've put this in there. So the pills that we use to treat the symptoms of Parkinson's, mostly the dopaminergic drugs, as you know, they can be behind some of the delusions. So they don't typically cause visual hallucinations, but certainly the delusions can sometimes arise as a side effect of these drugs. When you reduce or stop them, they go away. So anxiety is fear, which is out of proportion to the situation. And therefore, there's no obvious reason to be afraid, but it is a very visceral sensation. And it can be pretty severe and debilitating, and people avoid things that increase anxiety. And sometimes it can lead to panic attacks. Other times it can be there at all times. The main thing to say is that anxiety is treatable, and there's both talking therapies as well as pills that can help. So impulse control disorders, and this tends to get a little bit of press because things like gambling, shopping compulsively. Sometimes it's positive, there's extra creativity, and it's thought to be related to the dopaminergic treatment, so too much dopamine. And within that, there is this thing called funding. You might hear about it, where people repeatedly do the same thing. It's quite stressful for caregivers when that happens for family members. That is, someone's just constantly folding clothes or just doing one action repeatedly, and to and not doing anything else much. Right. Sleep disorder. So a number of people with Parkinson's do have insomnia. So it's hard to get to sleep. It's hard to stay asleep. And then we are asleep or feeling drowsy during the day. And that's a cycle that then gets, that gets set up. There is this other condition called REM sleep behavior disorder. It's got a strong association with Parkinson's disease. And again, it's something many of you would have experienced. And this is when we sleep, our brains are disconnected, if you like, from the rest of our body. So we are paralyzed when we are in deep sleep. And if this switch in the brain is not working properly, some of our dreams get transmitted to our body. So we may end up talking or shouting or acting out the dream. And we dream in this condition, in this state called REM sleep, rapid eye movement sleep. And so this is a REM sleep behavior disorder. And usually it troubles the person sleeping with them. But it can wake people up with a jolt and say, oh, I was just speaking something, or what happened there? Cognitive disorder is actually a big section. And this is essentially, by cognition, we mean general brain function that is not limited to one part of the brain. So the whole brain needs to work together for these things to work, or for these things to happen. And memory, judgment, planning, I'll let you read that list. And to start with, the problems tend to be mild. People notice it, but it doesn't really interfere with your day-to-day function. And we tend to call that mild cognitive impairment. And if it gets to the point that it's actually interfering with your day-to-day function, then it becomes a major neurocognitive disorder, previously called dementia. And it is a bit different from the type of cognitive impairments that we see in Alzheimer's disease or in stroke or blood flow related neurocognitive disorders. So there is a slight difference in what is affected or what subfunctions of the brain are affected. Just by definition, I've put this there, Parkinson's disease and Lewy body dementia, or DLB. It occurs, so cognitive impairment occurs at different stages, but that's just the way, because of the way people have divided up the syndrome. And it seems to have, the people with this condition seem to have a good response to the drugs that we use in Alzheimer's disease. And there's some evidence that there's the lack of this certain chemical that the Alzheimer's disease drugs target is actually lower in Parkinson's disease than even in Alzheimer's disease. Okay. Yeah. So this is something that is, of course, distressing to people themselves as well as caregivers. sometimes it's because of a delirium, and a delirium is basically um, an acute confusional state caused because of something else going physically wrong. Common ones tend to be urinary tract infections, chest infections, pain, constipation, sometimes a change in environment, just going from place to place, change in the lighting around us. Uh, of course, psychosis. So if my reality is different from yours and you aren't agreeing with me, that's going to cause agitation and irritability. But with psychosis, there's also a little bit of fear and arousal, and that can manifest as agitation, irritability. And as I said, they are not conditions of themselves; they are manifestations of something else going on uh, in the background. Um, So I just spoke to you about delirium, and the thing to do in an acute confusion state is seek medical advice, help, because if we treat the underlying cause, the system, the delusional state resolves by itself, and you just need support during that time. The earlier we can intervene, the better the chances that someone doesn't need to go into hospital. But if there's a lot of confusion, then just to maintain hydration and nutrition, as well as stabilize behavior, people may need to go into hospital. Um, okay, so that covers a spectrum of things. There may be some that I haven't touched upon, and rare things tend to be rare. Uh, so there is, if you see the previous slide where I gave the prevalence of these things, it's common, yet we don't tend to get that much help or advice. A lot of it depends on what local services look like, of course. But beyond that, there is also this thing of stigma where we are generally fearful of being labeled as mad or out of his head or demented or something. And there is also a little bit of this normalization that what do you expect? You got all these losses, and Parkinson's, as you know, is a condition of losses. So I would be depressed if it was me. And also, you know, till you ask, you don't know that there may be something that might be there that may help. So seek seek help if you think behavior, mood, uh, brain function, memory, things like that are changing. So we're looking at change, and are really disrupting your quality of life. That's what ultimately it's about. Uh, we do have medications. The other big thing, and I'm sure you hear this uh, ad nauseum, is exercise. You do have exercise groups within the Parkinson Society, and it's great not just to build strength for your Parkinson's, but it's also good for your mental health. And psychological interventions generally involve speaking about things with someone. They're structured interventions, therapies for different um, syndromes, particularly depression, anxiety. But there's also this thing of mindfulness that's come in, which is about monitoring ourselves and to a certain extent accepting things that we cannot change and working on things that we can. And so people have named this acceptance and commitment therapy part of mindfulness. And Of course, you're going to need help and assistance once your own reserves are used up. And it's going to vary from person to person depending on your situation at home. But reach out to your care providers and just even if you don't need it, even if it's a little bit early, do get an assessment from community health support services, and at least you are then in the system. If things get worse more quickly, you are able to reach out to someone. Again, the Parkinson Society itself is a great resource of information. Right. So it should actually say thank you to Kelly, but Kelly's joined new with Elena. But thank you, Kelly, for facilitating, moderating this.